Hi, I'm István Urban, and I'd like to thank you very much for attending this webinar about the regenerative approach for the management of periimplantitis. Now, we are all facing problems with implants, and you can see here different types of defects. And when you have a patient like this, the first thing you're thinking of is like a Shakespearean question: to regenerate or not to regenerate. And if you decide that you want to regenerate, the second question is, can I attempt a complete regeneration, or it could be more reliably an incomplete regeneration that maybe I can still maintain the implant? And the third question is, for my goal, do I need a transmucosal or a submerged healing to achieve my goals? And in my presentation, I'm going to talk to you about, kind of like at the end, kind of like a heroic type of trying to saving implants. And I will also give it my honest opinion if it's really worth it or not. But what can you achieve? But is it really like worth it in sometimes, or sometimes just like you can let the implant go or do something else? And so this presentation will be, the base of this presentation is a general principles of regeneration, with the assumption that we can clean the implant surface and remove the superstructure. My very first lecture was in 1999 about, and the title, I had to choose the title, and I gave the title periimplantitis. And this is a slide from my 99 slide when I had a periimplantitis, picture I took, and in the middle I put this rough surface like Manhattan surface in, and as you can see the problem is the surface of the implant. How can you clean it? And there was different types of approaches. We tried everything, lasers, air powder, different chemicals, and polishing the implant, and things like that, just doing a resective approach. And as you can see here, that these implants some of them are really, really ill, and they're really dirty. So how do we attempt to clean the surface of these implants? And you can see it at least with our naked eye, it looks much cleaner than the other one on the side. So that is, as you can see now, on the middle, the implant looks much cleaner than how it looked before, but maybe not perfectly clean. We don't know with our own eyes. I would also like to mention that today I would say the article that represents this type of regenerative therapy is a multi-center randomized clinical trial, which is the highest standard. And they found no differences between regenerative approach versus just, an opening and basically do a debridement and close. And in this article, they also said very well said, that there are difficulties in distinguishing a bone filler material on an X-ray than a newly formed bone, and that may influence the interpretation of radiographs in some of the articles, for example, or in some of your clinics. I think we have to keep this in mind, that what I'm going to show you is going to be cases, and some of them with very good follow-ups, but it's not a randomized clinical trial, definitely not a multi-center randomized clinical trial. Okay, we have to appreciate the work of these colleagues. Several studies showed that after surgical treatment of periimplantitis, they still reported persisting bleeding on probings at follow-ups. And we have to keep this in mind. Now, to regenerate or not to regenerate, and please take a look at this case that, I did an excess flap surgery in 2007, removed the superstructure, cleaned, removed the granulation tissue and just cleaned the implant. And I didn't have any particular way to clean the implant. At the time, I was using maybe my gauze, a cotton pellet or something. And I could not even believe that the bone grew back and the signs of inflammation disappeared. And this is in 2024, that's 16 years later, those two implants. And this is how the patient came, this is how the patient ended up. And in the study that I just mentioned, they show that this can happen. However, maybe not very frequently. Definitions of success. You can have a healthy implant after complete regeneration. That would be a category of A Or you can have a healthy implant with a reduced support when you maybe did something that, maybe resective surgery, but there is, resolution of the clinical signs. Regenerate or not to regenerate, like complete or incomplete. Like, look at this tooth. I mean, it's almost hopeless to try to save this tooth, but it's much easier to clean this tooth. And maybe you can regenerate incompletely for this tooth, and you would say that's a good, result for me to maintain this tooth. I mean, that's the point that I want to make, that maybe an incomplete regeneration is still allowing you to maintain the implant. So let's talk about the implants. And we can see that there are different types of defects. We can say the class 1 defect, which are, paper that we published. We just went from regeneration. Class 1 would be a 4-wall defect. A class 2 would be a 3-wall defect. A class 3 would be a 2-wall defect. And a class 4, a 1-wall, and then a supracrestal defect. And also you can have a defect, which is not a real 3-wall, but kind of like a facially missing wall. And usually these implants were placed like in an extraction socket, sometimes 2 buccal, and just lost the buccal plate, and not even producing like real signs of periimplantitis, but you can see the head of the implant, which may be aesthetically not pleasing. So that's like a separate category now. Let's focus on the real diseased parts. In 2019, I started to use an electrolytic approach called the Galva search. And this was, I think, the second case I treated. As you can see here, there's a little trough around that implant. And here, one compartment of the implant, which is supracrestal, was never really placed inside the bone. So let's focus on the infrabony component of this defect, which is kind of like a 4-wall defect. And let's open this up. And as you can see here, the defect is regeneratively easy, but it's difficult to access for cleaning, to remove the granulation tissue. I had to use like a periodontal probe. Now I'm doing this Galva search therapy, and I was very surprised that with my naked eye, how clean this implant looks. So then we just scraped a little bit of bone because we didn't want to make it very expensive. Scraped a little bit of bone because that was very, very small, walls of bone. So that should heal almost by itself with a stable blood clot, but I think it's better that we filled it in with some autogenous chips. And then we put a sterile healing abutment. The patient was okay not to put in the superstructure immediately because there was no abutment. It was directly on top. Collagen membrane. Well, we placed the collagen membrane like a poncho, but this was such a small gap that maybe it wasn't that necessary. Okay, and that healed uneventfully, but it's a transmucosal healing. Okay, transmucosal healing can be tricky because the transmucosal component could be almost acting like a fistula tract. If you don't really look around, maybe you don't see that. Okay, but I don't think it was the case in this particular patient. There was all the signs of inflammation disappeared, and it felt, it filled in. This is the first year of result, and then this is the 4-year result, and that shows, I would say, complete resolution of the defect, of the infra bony defect. Okay, so that's like a 4-wall defect, which we call class 1. Now, this is another one, which is the defect is far away from the implant. Here, I would definitely use a membrane. Use maybe biomaterial, use maybe your graft of choice, autogenous bone, mixture, but definitely the walls of bone far away, so I would definitely use a collagen membrane. This was a transmucosal healing also with sterile healing abutment. Now this one is an all-on kind of like X, but imagine if you would really need that implant, because I would, that distal implant, I would take out because that's like almost like 3 millimeters of the implant is left inside the bone. And I think this restoration, which is not the most beautiful restoration, but it could still work without an implant. And that's a 4-wall defect. However, regeneratively, a 4-wall defect is very well approachable and it's a good healing capacity. So we just clean it out, debride, basically remove the granulation tissue. We put in the machine, and did really look very good in terms of how clean it looked with our naked eyes. And then we did the bone graft, we did transmucosal healing and a collagen membrane, and not much of a keratinized tissue. You can improve that, but that's not an issue now. As you can see here, there's a radiological fill-in. And clinically, this is a 2-year, and I don't think there's a mistake of the X-ray here. There's nothing to probe here, and it does really look like that we got a complete resolution of this defect. Okay, so the forward defect, I would say open healing, it's like transmucosal healing is, I think, the way to go. And if the gap is more than 2 millimeters, I would definitely use a membrane also. The second class would be a patient who has a trivo defect. That means in this particular patient, the buccal bone is missing. In this particular patient, the lingual bone is missing, which is much more difficult than the left one, right? So you have a dehiscence and you have the trivo defect. Okay, look at that one. That's on the lingual side. So let me show you a patient that I treated with multiple implants. And this patient had an implant failure, so we needed to do a ridge augmentation, very narrow ridge. We did a sausage technique, which worked perfectly, and we placed some implants. There was no keratinized tissue. We didn't augment it. Patient was not, in her age, she's not very young, basically. 2010, I did reconstruct the entire upper jaw, placed the implants. All the implants are doing well except this one. So we opened it up, and we found that there's a trivo defect. The buccal bone is down, but the rest of the height is pretty good, looks really dirty. The machine works if you remove all the debris, like including deposits and also the soft tissue around the implant. And you can see how nice and clean this looks after debridement and the use of the machine. And then I said, okay, well, if this is clean, there's one way to prove it. Let's close the flap. And I even attempted to use a PTFE membrane. If there is 2 bacteria in here, they get married and the whole thing will blow up. So it's a primary closure, a submerged healing. And as you can see here, after a couple of months when I'm removing, I think it was only 4 months, removing, it looked like that all this implant is embedded in newly formed bone. And we even today did a histological check if was there any bacterial residue on the implant, but there wasn't. It was basically even osseointegrated, little bone pieces we removed when we removed the membrane. So, and that sounds very good. And now we uncovered the implant. We did a little soft tissue graft, a strip gingival graft. And this implant was somewhat facially placed, I admit. But as you can see here, it's clinically was a complete resolution, which usually you don't see, right? So the question was like, what do you see on the X-ray? Is it right or not? And I think this is correct. This is 4 years later. No signs of inflammation. There's good keratinization lingual, good keratinization tobacco, no bleeding or probing, and it looks like a complete resolution of the defect, which we confirmed clinically and radiologically. And so in normal implants, you can see that to completely regenerate in a normal implant, that a sterile implant that you place in a healed site is not so easy with the resorbable membrane, okay? According to a randomized multicenter clinical study that we did. And so fixation becomes a very important part of this. Okay, fixation becomes really important, especially when you have a trivo defect. So here's an implant that is our implant, and the distal implant is not doing so well. The middle implant is also maybe have a little bit of a problem starting. The distal implant has a real trivo defect, big one. Now this one, we need fixation. Before, we didn't do any fixation. This one, we need fixation. So here we're using the Galvo surge, and then we do a bone graft, and we do a trivo defect treatment we like to use some autogenous chips, maybe mixed with a biomaterial. You can use a biomaterial only also, but you need to fixate. And so we do like a sausage technique, and this was a submerged healing. And healed very well clinically, radiologically, and when we reopened the situation, is almost a complete coverage of the implant. And 2 years later, so that you can see how nicely this, massive defect disappeared. And you can see that we did very good conservative therapy, like debridement a little bit, and conservative, very good hygiene on the middle implant also. And here is at 2 years, here is at 3 years. The middle implant is also doing pretty well, the posterior implant doing great. And yes, there is, you can maybe augment a bit more soft tissue. I think this is very hygienic, and the patient's cleaning it very well. Okay, so did I have any complications? Let's take a look. Here's a patient who I treated. This is my very first patient, and I was not completely on focus in terms of, as you can see here, the trivo defect, but I was not maybe removing all the soft tissue remnants from the implant before I applied the machine. And as you can see here, this is the defect. This is what I was doing it. And you can see, I can see even that there's a little soft tissue on the implant, okay? Not much, but maybe it's covering some bacteria potentially, or biofilm, that the machine could not get access to. And I'm telling you this because it started to heal well, but it became not a perfect healing. So here, I said, okay, let's do it. I filled in with a bone graft. I did a bone graft on the buccal. I did a PTFE membrane and a submerged healing, which might be an overkill. But remember that this is in 2019 when we really wanted to see, did we really clean this implant? Because if this would work out, then, but it looks like that we did clean. Because it was even for us, we looked like that, oh, it looks really clean, but, I just want to know that, a little bit more. So, and the best way to regenerate this is this. You close it and you fixate, and even with PTFE membrane or a very good sausage. And it healed perfectly. But that's a 19, December 19, in 19. This is a 20, this is 20. And then it started to look puffy to me. In a couple of months, like 4 months, I open it up and I see something that we call a low-grade infection. Okay, so please read this article if you want to read more about low-grade infection. And low-grade infection, you will not lose the entire bone graft. So this is what we got. This is before on the right side and after. Now, it's very interesting that the angular bone defect, infrabony component, disappeared. Some of the component on the buccal disappeared. Some of them was even maybe getting worse. And why? Potentially, I left maybe a soft tissue remnant on the implant or something like this. And here we said, okay, well, we're not going to give up so easily. We used the machine again. And now we did a transmucosal healing because it was like a little bit too much of closure. Transmucosal healing with a sausage, which is, as you can see, it's stretched out really well, stabilized, sterile healing abutment, closure. Yes, no superstructure back, but for this patient it was perfectly fine for having, 3 weeks of, usually it's about 3 weeks that I like to have an initial healing and then put the superstructure back for this type of patients. So for this particular patient, this was fine. You can see here that it's really pushed up to have more of a buccal contour around the implant. And that's 4 years later. And clinical signs are pretty perfect. And we had to take a CT scan for other reasons. And you can see here how good this implant is covered with bone. So what do we know about transmucosal healing? Now, here you can see an implant that was extracted, an implant was placed, which is crazy. I know it has nothing to do with periimplantitis, but it looks, we extracted it, we did a mini flap, we did guided bone regeneration on the buccal. This is how it ended up. And we'd have done that for 20 years, and we're going to publish this for 20 years. Why am I telling you this? And there's one article with Dr. Joseph Kahn, which was published, that for sterile implants, new implants, it does work. So then it can work if you can clean an implant. And this is like a trivo situation on a sterile implant that we just placed in a defective extraction socket. So the message that I want to say that here I just did a sausage with a transmucosal healing. Do we have any idea of a sterile implant? Did anybody did anything like this? And we can say yes. So if we can clean that implant, that's what I said, if we can clean the implant at the beginning, then maybe we can apply our general knowledge of regeneration. So what do we know about class 2? Class 2, I would say no PTFE membrane is necessary. The sausage technique using a well-fixated membrane. Transmucosal or submerged healing, I think you have to pick your case, and you should, I would go for transmucosal healing as much as possible, and maybe not getting all the time like 100% result. But submerged healing, I would say it's probably better. Not probably, it's very, very likely it's better. Here's another case when this is a class 2 patient which has second molar. All the implants are doing well except the very back one in second molar, 4 threads exposed. And there is a trivo defect because there is like a trough on the buccal. Now this is very difficult to regenerate. And here we have done a biomaterial in combination with some growth factors, which I'm just mentioning here. We just recently published an article on a growth factor that is a microdose of the BMP2. You can read this article here. And okay, so with the biomaterial and the microdose of growth factors, you may have a chance to easily reconstruct. But I know it's not available everywhere. Anyway, so here it is. It's a vertical sausage, submerged healing. Here is with the growth factor, but in general, you can use it without the growth factor, obviously. And so good pinning, very good fixation, but we're asking a lot is a dehiscence on the lingual, but it's a trough on the buccal. And theoretically, this could work. However, I would say second molar in the mandible, on the lingual, such a defect is very difficult to regenerate. And submerged healing was attempted here, that healed perfectly, and 4 months later, as you can see here, all the 4 threads are completely covered in bone. Okay, here we use the microdose of BMP2. And you can see here on the buccal, you can't even tell that there is a biomaterial in here. Okay, so this was the class 2. Class 3, I'm going to show you one case, and you will see that this is a much more difficult defect. There is no, in this case, there is no buccal bone, there is no palatino bone in this particular patient. And you can see here, I'm going with the probe all around. Implant is barely inside the bone. Yeah, I mean, if you lose this implant, it's going to be a none on 3. And so this implant looks very, very important. It's really clean now, a good sausage, transmucosal healing. I think it looks good. However, palatinal pressure on the collagen membrane can be substantial. And so I would say this one is a little bit of an overt stretch of the what we know about regeneration. Because if you read the collagen, the resorbable membrane studies in normal implants, which are virgin, basically sterile, it's almost impossible to regenerate a defect like this 100%. Especially with transmucosal healing. So this was before, this was after the graft, but then we started to see inflammation again and started to break down. So very likely we got a partial reduction, initial, that got reinfected, and basically it started to break down again. So the bottom line is this should have been a submerged healing, but then you need to do some type of temporary for the patient, submerged healing, and potentially another type of membrane. And you can see one here that is, you can see the defect. And here we said, okay, well, how do we submerge this implant? I mean, there's like 3 implants here. There's breaking down the mesial implant. What if we just get, like an incomplete regeneration and make the whole thing maybe more maintainable, manageable? Maybe I'm showing you like also difficulties and difficult decisions, because I could do a submerged healing and a PTFE membrane, because that would take a PTFE membrane to completely regenerate, or I can do like an easier technique using just a collagen, biomaterials, and maybe growth factor, maybe not. And here you can see radiologically, here's is like you could say, oh, well, I regenerated, but normally people are not opening up and see what happens. But here, we wanted to take the pins out, wanted to see what's happening. Submerged healing, very good healing. I had to exclude the distal implant from the flap. Because think about this, if you include it, I would use the Galvo surge on that implant too. And so it's a very constricted area. You can see we got some horizontal gain, but not much was covered of the implant. I mean some. The implant was covered, maybe we have a initial picture in here. Anyway, so maybe like 2 threads are covered. Now, what do you do with are you going to put this restoration back as it is, and you say this is clean, and maybe patients and we're going to do a better job maintaining it? That's one way to do it. Or some people would like to polish the implant and make it like a tissue connection type of implant. So we kept it like this, and we really closely look at that patient. Now, class 3, we have here a buccal and a palatino defect, close healing. Titanium reinforced membrane could result a complete resolution of the defect, but it's challenging. You need a submerged healing. Sausage could be an incomplete regeneration, but transmucosal healing potentially will result with a less favorable approach. And I showed that to you that I would say for this type of patient, yes, you can do a collagen membrane, very well fixated sausage, but it's better to close the flap on top of the implant. So submerged healing. One more defect. I mean, this implant, it's very unfortunate, this implant, because basically the tooth failed in front, and then the whole thing, by the time we saw it, the whole thing was down at the apical level of the implant. We cleaned and cleaned. And then doing the extraction, and this is what we have seen. And it wasn't that bad when we opened it up. But the problem was that now we want to put another implant, and there's a knife edge. And what do I do? Because that implant, if I do a bone graft, is going to infect my bone graft for sure. So can I attempt a vertical reaugmentation here? And here we go. We use the Galvo surge. You can see the bubbles. You can see how clean it looks. The anterior portion is narrow. And if you want to regenerate this, you have one shot, which will be a PTFE membrane. And here you can use a bone graft. You can use here some collagen with some growth factor, or just a bone graft simply. And you can see here a very well fixated membrane. Now we're trying to regenerate, not that, that implant could be maintained like that, but if you want to do a bone graft in the front, I need to make sure that it's clean. And if it's clean, then I just connect the whole thing. And here it is, and this, you can see the uneventful healing. That means that there was no bacteria in there, because that would blow up. For sure. You would see fistula tracts, pus, and things like that. And you can see here that there's a pseudoperiosteum under that kind of PTFE mesh. And but there's clearly very good bone formation. In some areas, distal you can see that bone is covering the implant. So it's almost a complete resolution for this implant vertically, and I placed an implant mesially to restore that. This is how the defect was before, and this is how much bone gain we achieved. Now, I have to say that I tried everything in the last 25 years, but I've never seen, and I would never even attempt anything like this before. That's my private opinion. And so one more defect will have a close healing, will have a titanium reinforced membrane, okay, if you regenerate, or consider just access surgery and implant removal depending on the advancement of the defect. Some people like to plastic the implant, some people don't like that, but that's it's a different approach. But consider access surgery, implant removal depending on the defect. But if you want to regenerate, it's a titanium reinforced membrane. The next category of patient is going to have a vertical defect. Now, vertical defect, obviously, why would you do that? And how would you do that? And how predictable is this? Read these 2 articles about, in general, principles on vertical reaugmentation, if you're interested. And read this article, because let's say you have a case in the mandible, which I'm going to have now. And so how will you perform the closure? And you need to have a lingual, and you need to have a buccal flap that you can advance. And you can see here that in this article is very well described, I think, the dense connective tissue, how we can use it. You can see here the lingual nerve inside the dense connective tissue. So the point that I want to make, that once you enter to this area, it's an advanced surgery. As you can see here, there is also the mental foramen and the mental nerve. And you can see here a flap advancement completely making sure that the mental nerve is not harmed. And so here's an implant. This implant is very, very close on the mental foramen, okay? And this is how it's a vertical defect. Now, the next tooth is a problem, okay, the next implant. Because now I'm in a very, very restricted space. If this implant would stand in the middle of nowhere, I would be pretty much perfect. Because I was using the machine was cleaning it out really well. I was, able to harvest some bone, and now I'm doing the lingual flap advancement. That's like a third zone, a little bit on the second zone. And I'm doing a very careful advancement around the mental foramen. You could just polish this implant. You say, yeah, why don't you just polish the implant? Because we're talking about regenerating around an implant. Okay, and I'm trying to regenerate around an implant because we need to know what we can do with the device and what we can do, for some of the patients, for some of the implants which are critical. And you say maybe that is not one of the most critical implants, and I think you're correct. But the problem, and I already knew that during the surgery, that I'm very, very close to the neighboring tooth, and I kept that implant out of it with still having a ring of soft tissue. However, today I would remove that abutment from that implant, include that in the flap, use the Galva surge on that implant, because this was healing uneventfully. But once they put the provisional back and they put that with cemented it back, and a little bit of cement went through that sulcus and touched the membrane, so I had to remove the membrane after a couple of weeks. And because of that, we got bone, but it's not perfect bone. And here I decided, knowing the patient, that I just polished the rest of the implant and created a tissue connection implant. And so small supracrestal defects we had tried, and we had some success and some incomplete, but I would say pre-success, but some incomplete regeneration. So let's see this one, 3 implants. And here I have one with the distal implant is a 3-vo defect. Again, lingual, 2-3 threads exposed, and a trough around the distal implant. The middle implant has a perfect 3-vo vertical defect exposure. What can you do? You can polish the implant, resect, or just debride and do nothing else. Or, here we go, we did the sausage one. The distal, we said, it's 3-vo defect. Let's do a transmucosal healing so we can put some teeth back. And the middle, it's a vertical defect. We did vertical sausage. Very well. Now you can do 2 ways. One, you scrape a little bit of autogenous bone, put it like I did it before, a little bit of autogenous bone, biomaterial, PTFE membrane, well, in between these 2 implants, it's very close. Or just a vertical sausage, removing and cleaning the mesial implant, which has no problem also. Why? Because you may have some bacteria around which you don't want to have an infection with, because now we include it in the flap. Or using a growth factor in the United States, like the bone morphogenetic protein is easily available. A microdose could work, which we use here very well. And here you can see the healing, which is excellent. And you can see the 3 threads disappeared. Maybe a tiny little bit of a remnant. The distal, we don't know because we don't uncover, but we see radiologically the distal is doing pretty well. Clinically doing pretty well, and so we saw in our own eyes in the middle implant that we grew almost 3 threads of bone vertically for that implant. Very small defect. This one was crazy. One of the first 3, 4, 5 cases that I've ever treated. And obviously, you want to remove this implant. Now, patients said, please don't remove my implant. I said, well, I would remove this implant. I would explain to the patient. I said, you know what? Okay, well, we have this new device, 2019 we're talking about, or early 20. And so we used the Galva surge. But I recognized, and you can see it on the mirror, that this implant has these little grooves, and the calculus just doesn't want to come out. So we said, well, we have to use something. And we used the titanium brush. But now with the titanium brush, you're modifying the surface. So when you're modifying the surface, then you're not going to get osseointegration for that. What we used the Gavo surge, so it was an ongoing cleaning and then the brush and then cleaning. I used twice the machine on it. Then I did the bone graft. This patient did not have any vestibule to begin with. There was no keratinized tissue, but we can still manage the closure. So I was not really worried about the closure. Okay, closure, PTFE membrane, because it's a vertical defect. There's no other way to do it. Submerged healing, there's no other way to do it. And it healed. So, did I clean the implant pretty well? I think I cleaned it very well, because in my experience, if there would be any bacteria in there, I would not look very good today. Very early on, earlier than the bone maturation, we went back, we wanted the membrane out. And we knew that the first 3 millimeters is modified. There's not going to be any osseointegration. Anyway, we can reduce an incomplete regeneration. If we can have an incomplete regeneration, maybe this implant can be maintainable and put like a soft tissue graft, which we did. And let me see. As you can see, that's the only picture I have. You see that is a very early bone formation, but you can see that there is hard tissue formation on the whole thing. It's just, I don't think there will be osseointegration. And you can see here that we grew bone. Yes, that part which now you could polish or leave it as it is, got some bone. Okay, and that's almost 3 years later. There was another implant placed and some restoration in another office that was done for that patient. Now, submerged vertical augmentation of supraosseous periimplant defects. So we have this publication, and we don't consider this publication as that it's showing you that you should do vertical augmentation on an implant. We show this publication and that it's not impossible to do vertical augmentation on an implant. You need, for sure, a device that will clean this implant really well. Now, you can see that those implants are not doing great. And you can see why. I mean, those implants, look at that restoration. I mean, how on earth would you clean that? Now, if you're going to get in there and do a bone graft surgery on these implants, at this stage, on this soft tissue, you don't expect anything really well, anything really good. So first, conservative therapy, mature, have some tissue maturation. I even removed the mesial implant. Patient I would have removed both of the implants, but the patient really didn't want to remove the implant. I said, well, perfect. Okay, let's do it. But you need to have some cleaning. Now, this patient, we cleaned it, but then we didn't see the patient for a while because of COVID and all that. But anyway, look at that distal implant. That has a 4 millimeter vertical defect. Okay? And then once everything was, settled, we placed another implant, tissue connection, by the way. Then we used biomaterial and some growth factor. And we used a vertical ridge augmentation, traditional submerged technique. And here we said, well, if we're going to get it, this is the case when we can get it. Okay? Let me go back and show you the defect. It's a circumferential defect. And here it is. And here's the healing. And here is the bone covering the entire implant. And look at that. The palatinal bone was completely missing, 3 millimeters on the palate, 3 millimeters on the buccal, and implant completely covering. The bone completely covering the implant. So, okay. What was my message for the vertical defect? That is not impossible. Okay? If you have a device or something that you can clean a diseased implant surface, then the principles of regeneration come into play. However, the question is, how many times are you sure? Do you really have the this is expensive. Number one, is this cost? Is it going to be worth it? Number two, do you really have the all the time the clinical techniques to do vertical ridge augmentation? I think you should. Okay, well, this type of implants, they have a facial recession. They have, I did the right side, the lateral incisor was coming with a recession. I did a connective tissue graft a long time ago. And now she says that please cover the other 2 implants. I said, this is a different ballgame. There's no papilla, they're all out. So, how can you make all that fake ceramic disappear with soft tissue? Very difficult. So we did the 2 vertical incisions so we can get an access to clean the implant surface. But at that time, we didn't have the Gavo surge. I did a connective tissue graft under the papilla, cleaned the implant surface with whatever I had, I had some improvements, but I had a reinfection. I mean, I could see the discharge. So then we got the machine. So we went back and we, disinfected the implant, put another connective tissue graft for the papilla and on one of the implant, and another connective tissue graft on the other implant. Use just the Galva surge. So yes, it's like 3 connective tissue grafts. Why connective tissue grafts? Would be much better to do some bone and the soft tissue, but the implant is already sticking out of the bone. So I think that's the best you can have. And again, I did it first and it worked, but it didn't work so well. And then I started to see that this is now really getting down, and you needed to change the restoration with getting a papilla back. And this is how the patient came, and this is how we restore the patient. And you can see this. This is 34 months after that this was almost completely symmetrical to that side of the papilla. I was hoping that I have a full picture on it. There is no disease clinically, okay? And I mean, that was like a tremendous defect. And so the message is that maybe we said, okay, we're not really intent to regenerate this. We don't want to remove the implants. It looks ugly. We want to improve this. We tell the patient, look, we don't know if it's going to last forever, but hopefully it's going to last for a long time. But we did. Okay, we're not regenerating bone, so it's a incomplete regeneration, but with the soft tissue and the cleaning of the implant, maybe we can get some type of attachment in here. And there you can see, I think it's a pretty beautiful outcome we got, okay, especially how the patient was coming. So, when you see a peri-implant defect, you have to consider the following: location of the implant, proximity and the conditioning of the neighboring tooth and the neighboring implant, soft tissue quality and vestibular depth and keratinized tissue, obviously. But I would say without a vestibule and keratinized tissue, you can still cover them. But then what happens after? Okay, you probably need a soft tissue graft, which we didn't really talk about. But so think about this: if you have multiple implants and in the middle is diseased, how small is your flap? If you extend your flap, I would recommend to use a machine on neighboring implants too, because you want clean in one flap. Because if you leave any bacteria in there and you close, or even if you don't close, but you can have a contamination of your bone graft. So think about this. Okay, so we have published an article on decision tree, and let me make this more clear than on this picture. Okay, a 4-wall defect. Open healing, I wrote, this is considered transmucosal healing. It's just shorter to write. Open healing with a resorbable membrane, where the gap is bigger than 2 millimeter, use a membrane, resorbable membrane, and you should be able to get a complete regeneration. A 3-wall defect, you can have a transmucosal healing, but very likely you will have a little bit less favorable outcome. Submerged healing using a sausage with well-fixated membrane, then you can have a complete or a majority of the defect will be gone. I think these are the 2 patients that you should really consider for regeneration. The third one, when we have buccal and lingual dehiscence, is getting a little bit difficult. Submerged healing is mainly recommended, and transmucosal healing with a sausage with less favorable outcomes. I showed you one. Titanium reinforced membrane could be resulting a complete resolution and submerged healing, obviously. The sausage would be an incomplete. You would say, okay, I want some bone, but then I maintain the implant. And then you would do sausage. If you want this defect to disappear, and you feel that this is the case when you can, it's a must to have, and your neighboring teeth, your neighboring implants are such, or they don't exist too much, then you can attempt to use a titanium reinforced membrane. Supracrestal, 1-wall defect, supracrestal defect is almost the same. If you're regenerating, it's a submerged healing, it's going to be titanium reinforced membrane. However, consider resective surgery, just excess flap, or resective surgery, or implant removal for this type of defects. But I showed that it's not impossible to do a vertical rejuvenation on this type of patients. And with this, I hope you enjoyed this. I just wanted to give a little bit of an information of our experience. And again, I would like to emphasize this is an experience, which is a good experience, but it's not a randomized multi-center clinical trial. But I'm sure this will be done soon. And yeah, I think there's a new thing on the horizon, which works really well. And with this, I thank you very much for the attention. Hello, everyone. Again, thank you very much for watching the webinar. And I got a lot of questions, and I try to answer as many as I can. And there is like a question about what is the best regenerative material for the exposed implant threads. Well, I think the most important thing is that the implant should be clean. You should do a bone graft that it doesn't move. And you should you should do like either transmucosal or a submerged healing dependent on the defect configuration. And then I think your regenerative material, which should be a good one, should work. Okay? Some autogenous chips may be on the implant surface, a mixture of autogenous chips and a xenogenic bone graft. Potentially some even allogenic bone grafts with xenogenic bone grafts could work. But of course, when you have like a big vertical defect and and you would attempt to regenerate that or regenerating that, then I would use at least 50% of the autogenous bone. The next question was also a very, very good question, is like what cover screw would you use for a submerged healing? Number one, a sterile cover screw. Okay, so I would take a new cover screw, and I would not use anything with like a height. I would probably just use a normal cover screw. And and if I want to bulk out the tissue, I can do the bone graft on the fascia and a little bit on the cover screw to tent it out, especially for a submerged sausage. I think that would be very, very helpful. And there was several questions about the pins, the pin system that I use. I don't think it's so critical which system you're going to use. If you're not going to use it in the mandible, you need a very, very strong pin. Like I use the master pin, but in the maxilla, probably other pins would work very well. In the mandible, it's very hard, like you need something that goes through flawlessly into the bone. And also like we have different screws that we can tighten the membranes with. So the pins are easier for the collagen membrane. Most of these will be collagen membranes. So there is a question: what if you don't use the Galvo Surge? What else can you use? I mean, look. I mean, I tried everything. I tried all chemicals, just saline, air powder. But to me, nothing worked as good as this. So I was not very successful before. How perfectly clean the implant surface? That's a very good question. I think I addressed that, because we just look at this with our own eyes. I mean, it looks very clean. And when you have a submerged healing and you get bone, that means you cleaned that implant surface. Okay, that's the best way to get a feedback. I think it cleans it really well, honestly. And soft tissue augmentation simultaneously with bone augmentation or staged? Well, well, you can do actually a periimplantitis treatment with a regenerative approach and a soft tissue graft at the same time. Okay, you just have to have the techniques for that. And did I ever do that? Yes, I did it, but I did, like, for example, transmucosal healing on a class 2, like a trivo defect, and I also added a connective tissue graft on the facial of the flap inside. But in general, it would be a staged approach. You would do the regeneration, and you would mostly want to have keratinized tissue, which is like an open healing soft tissue graft that you would need to do, after. Or you can do it also before. It's kind of like a preference. The after has the advantage that you really precisely, and you're not going to move that anymore. If you do it before and then you do like a submerged healing, you may distort the keratinized tissue. And so, okay, what is the name and the brand of the device? It's called the Galvo Surge. And I don't know what the brand is. That's the name, and I think it's just a company which is doing this. And how is the implant cleaned? Okay, there was a question about on those noble implants with a sloppy connection, do you think fixing them is worth? Yes. So number one, I don't think it's about a connection so much. If you are going to treat them, and I think you can treat them, it's probably mentioning the old, external hex connections, which, I mean, many of those implants are in the mouth for 50 years with the external connections. So it's not about a connection. It's about, if you regenerate, you get you give the patient maybe good keratinized tissue, good hygiene, and good follow-ups, then it should, of course, it's worth it to regenerate. And you can regenerate these surfaces. Which membrane tech system? I think I mentioned that. Removal of granulation tissue. I think it's a very good question. I basically, if you want to be really careful, you can use a titanium curette, but I use a periodontal probe or a curette. I don't really touch the implant with it. The granulation tissue is very easily coming out. When you have a very narrow trough around the implant, sometimes you can only fit a probe, and with a probe, lucky enough, usually it comes down very easily. Okay, but then you have to check if you leave the number one deposits, or you leave soft tissue still adhere to the implant, there might be some bacteria still in there, and then you're not going to, because then the gauge surgeon is not going to touch that area of the implant. So you have to completely degranulate. PRF membrane or collagen membrane. I think collagen membrane, definitely, if you use PRF, you can use PRF, but I think it has to be a bone graft that is stable, and you should diagnose your defect. You should choose your approach, and that's what you should do. Let's say you have a class 2 3-row defect. You're going to say, okay, I can do this maybe with a transmucosal healing. I need a sausage, so I need a collagen membrane. I need titanium pins to completely mobilize. And basically, that's the most important. To be successful in regeneration, in this area especially, you need what? A clean implant. You need a good graft that is not moving, and it doesn't get infected. So it doesn't get infected from the oral cavity or from the implant. If you clean the implant, it's not going to get infected from the implant. But of course, the oral cavity is also a risk. So that's why transmucosal healing is only for selected type of defects. When you know that you have stabilized so well and you sutured so well that you should not get an infection from the oral cavity. Etiological factors of periodontitis basically is bacteria. Active periodontal disease. Yes, I mean, if you have periodontal disease and you put in implants, you definitely have a very high chance to get periodontitis. So if you treat periodontitis, you have to also treat periodontal disease. I think that's really important. Yeah. So the question was that when I showed the patient who with a vertical defect, okay, type of provisional, very good question. I mean, that was a very favorable case because that was patient had 2 implants. One I had to remove. The other one had like this maybe 4 millimeter vertical defect, and it was in the posterior region, not really like a high-end aesthetic region. And when I did the bone graft, I didn't put anything on it because it was a submerged healing. There was a membrane. I cannot really put much of a pressure on it because that would not be very good. So definitely, I think this is also, come into play when you do this. When let's say you have a class 3 defect, when you have only 2-bone defect, you have no buccal bone, no palatinal bone, and let's say you do a non-sub, like a transmucosal healing with a sausage because you soon want to reconnect the prosthesis, you're not going to get 100% bone. And but you're going to have sooner some temporary or final solution for the patient. So I think these are very important questions. Okay, PRF over the PTFE membrane, me not, but you can do it. The PTFE membrane, if anybody is choosing to use a PTFE membrane, it's a submerged healing, and you have to have some experience with it. Okay. The PTFE membrane is just one kind of like stable membrane. You could use a titanium mesh. You could use something very similar. But the most important thing is that you should be able to have a surgical skill that you keep that soft tissue closed. Do I have experience with laser? I do have experience with the laser. I have better experience with this machine. Why do I use the PTFE membranes? Because of stiffness and stability? Yes, form stability. So in certain defects, like a class 3, if you want to completely regenerate, definitely you need something form stable. And because then, the pressure from the palate, maybe more pressure from the buccal, this is all protected by this membrane. And also a vertical defect. How long do I wait to put the superstructure back? Very good question. I showed, during the presentation some cases when I did transmucosal healing, and I used a sterile healing abutment. Depends. If you have an abutment, like let's say a multi-unit abutment between the implant and the crown, that's easy. Then you remove, you disinfect it, you can put it back right away. If it was restored directly on the implant, I prefer to put in a healing abutment, especially in this posterior, and I never had a patient I tell the patient, look, this would be much safer if I put a healing abutment and wait about 3 weeks to exchange that and put the restoration back. I never had a patient that was really arguing with that when I told the patient that it would be much safer. But of course, maybe for some patients, you have to put it right back. But if you have to put it right back, please remove the screw. And if it's directly on the implant, remove the screw, disinfect the hell out of the whole thing, okay? And put it back to make sure you're not going to get a contamination from the superstructure to your bone graft. Okay, there was a question about provisionalization here when there was the papilla and the large recession on the central and lateral incisor. How did I do the provisional? We did the provisional like a plastic provisional. And I think we had for the first week or so, we have done maybe a Maryland bridge, but you could have put back like a provisional if you have one. Those final restorations were useless, so we couldn't use that. So I think we had either an Essex or a Maryland bridge for a very short period of time, and then we had the provisionals. But you can do immediate. I mean, you can take an impression and fabricate or scan and fabricate the provisionals by the surgery, and I think those are very clean, and you can just put it back. However, if you do like a partial coverage of the implant, then it's better to do wait a little bit. Titanium brush. Okay. Well, how does it change the microsurface? It does change the micro. If you use a titanium brush, it will change the microsurface, the surface of the implant, and your re-osseointegration becomes really questionable. So I think it's good for removing some calculus and for, just like maybe doing debridement surgery. But combining with the regenerative approach is a little bit difficult. And it's almost impossible. I did one case when I did on the top, because it was in the grooves, the micro grooves, there was a lot of calculus that I needed to use something to remove, but I didn't get any osseointegration there. Okay, what about autogenous bone and xeno mixed or layered? Very good question. I think if you can scrape enough, I think layered is a little bit better, but I would say some autogenous and then a mix. Sometimes we do a 3-layer, like some autogenous layer, well, a mix autogenous and a little xenograft, and maybe just a tiny smidgen layer of a xenogenic bone graft. We do that for the dehiscence in like normal sterile implant surgery when I place a new implant, and I think it can be used here, but definitely you can maybe use this xenograft only, but I like to use a little bit of a mixture of a layer. Okay, if in the anterior mandible you have a lingual side problem, how do you do that? Okay, well, that's something which is very technically demanding. Could I do it? Yes, I could do it. But then I would have to do a lingual flap on the anterior mandible, which I can do. I have to completely disinfect the implant. Is it only the lingual or it's also buccal? Let's imagine it's just the lingual. Then it's usually it's just sticking out so much of the bone that it becomes like a anatomical almost impossibility. But let's say you can do it. What I would use is that probably I would use a titanium reinforced membrane, submerged healing, and the self-tapping screws, such as for example, the Profix screws or similar screws that, master pins that you can fixate. But I'm sure there's many others that you could use. Do you give the patient antibiotics? Very good question. Yes. Which antibiotics? Well, I when I clean the implant surface, I use the same antibiotics as for normal regenerative surgery, which is like amoxicillin, if the patient is not allergic to penicillin. And obviously, augmentin and augmentin metronidazole would be something, more potent, but I don't think you need it because you either cleaned it or you didn't clean it. If you didn't clean it and you put a graft on it, the antibiotic is not going to protect anything, okay? So just a simple amoxicillin. And in the submerged healing today, it's even questionable that after the first dose you should give at all. But we do give for a week. And we use amoxicillin. What about just an implant which has some crestal remodeling, excessive or more crestal remodeling? That's a question, but no periimplantitis. Would you do a reus integration? Well, yeah, I mean, theoretically, you could do it. Where would you do that? Let's say you have an anterior maxillary, like 2 implants, and you feel like you don't want to take them out. But it is very easy to take them out and put a new implant and do the steroid regeneration, or you can do this. But I would always like to say that if you do a vertical ridge augmentation on this, you have to know, consider a lot of things. Your technique, is it right? Do you really know how to do that? How much keratinosis you have, how much vestibule you have, how much distortion you can attempt. Okay, what will be the soft tissue after that? So yeah, think about all this. Okay, suture dehiscence ratio. I think I hear that all the time that when you use this, it's going to be much more. I don't think so. I think like that is absolutely not a problem. Like it's not going to, I mean, you cleaned it, you closed it, it's going to stay closed. If you didn't clean it and you closed it, it's going to open up like this, like a bomb if there is bacteria. But like I don't see that. So I don't see any openings because they're closed. If you would have a microinfection, you would see maybe a fistula, but not like a membrane exposure. So I don't think that's a problem. Okay, how do you disinfect and clean the prosthetic reconstruction? Well, that's a very good point. And yeah, I mean, I think you just have to, I use usually I like to use a new prosthetic screw, sterile, and we just disinfect the superstructure. My favorite bone graft, xenograft or allograft. I really like xenogenic bone grafts and autogenous bone together because they really work perfectly together. Yeah, soft tissue grafting before and after. I think it's by the case. You select it. Some people like to do a soft tissue graft before to get leather a little bit easier, like maintaining the patient easier, so it will be less inflammation. I think if you really do a very good job with the pre-surgical, then I would say I would actually prefer to do it after, perfectly precisely. And in some cases, maybe before, if I would say that is like such, pockets and such inaccessible to the patient to make the tissue a bit lower down, to make it more stable, make it more fixed, so the patient can clean better. Cortical perforation benefit, nobody knows. I think in a mandible, definitely, it's more bleeding, it's more better blood clot. But I've done an animal study on large animals without any perforations that we got perfect bone. But in humans, nobody really knows. Okay, bone graft mandatory bone. Yeah, there's a question about BMP, demineralized bone, allogenic bone has some BMP. The BMP, which it has, demineralized freeze-dried bone, is not a lot. Okay, so I would say that is not something that I would biologically consider as a big advantage. But it resorbs a lot, so you would have to protect it with a xenogenic bone graft. If you use DFDBA, it's really resorbable, protect it from the outside, like if it would be almost like autogenous bone. How can you make sure if the implant is totally clean? You cannot make sure. You would need a microscope, but you will see the healing. If it wasn't clean, your healing is not going to be very good, especially submerged healing. I think I showed you that I did a submerged healing PTFE membrane, closed, open bone. Was it clean? Definitely, because if there would have been bacteria, you would have the problem. Contraindication for the Gulf surge. You have. I don't see. How somebody would be allergic to this. I don't see that. Postoperative instructions, just like a normal surgery. Take the medications. If I did, like, let's say, like a close healing and I'm expecting some swelling, put some cold packs especially for the first 24 hours, and don't eat anything with little seeds, which can get stuck into the wound area. Nothing else. Can the soft tissue augmentation replace GBR? Okay, so it's the same old question. I don't think so. I think it can improve a lot, soft tissue augmentation and hygiene, but the complete reconstruction with keratinized tissue also would be much easier to maintain. There's a lot of if I use Cooley technique in my practice, definitely not. Why would I do that? I mean, of course, some people like to do that, but I don't see why I would do that. Polish sucrose. Yeah, so going back to that question, yeah, I think GBR you can use from any defect. So I don't plan to change that in the next 2 decades, maybe. I'm just reading some questions. Yeah, very good question. If the peri-implantitis is accompanied by severe peri-implant mucositis, is it advisable to first reduce? I think I showed that. I showed you that was like a disaster soft tissue. And you don't want to get in there and do surgery immediately. I mean, you want to instruct hygiene, you should clean, you should get ready with the tissue. And that's why some people like to do even a keratinized tissue graft before. But again, that's just reduce the inflammation. And of course, I think the phenotype is also very important. Okay, and I showed the second molar on the lingual, very thin phenotype patient, no keratinized tissue to begin with, and still managed to keep it, closed. Because if you suture in 2 layers, I don't think that's really a problem. I never mix antibiotics into my bone graft. That's a question. There's one, I don't know if they published already or not, but they did an RCT here in Budapest, and they did one side with the bone graft and antibiotics, the other side without. And where they did the bone graft, the bone formation histologically was worse, much worse and they got infections even in the area where they put antibiotics. I don't think this is a very complex, biological process, bone formation. I don't think I really want to play with a chemical in there, especially if it's never been really investigated. What do you do if you get a postoperative fistula? Very good question. And I think that's a very difficult answer. If I would get let's say you have a submerged healing, you get a fistula, that means that you have a low-grade infection. If you have a low-grade infection, then it's a race between bacterial invasion and maturation of the bone. So you could take a radiograph, you could even take CT scan, theoretically. However, I would avoid that because of radiation. Dependent on the defect, I would maybe keep the patient let's say if it happens in the first 2 to 3 weeks, let's say 3 weeks, you see a fistula. I would look at, okay, what type of defect I have, what type of membrane do I have? Do I have a submerged? Do I have a transmucosal healing? Let's say I have a submerged healing, collagen membrane, 3-wall defect, a little fistula on the buccal. Not very good news, but I would say I would like to maintain this whole thing, for at least 5 weeks. 5 to 6 weeks, you have a pretty good quality of the bone. And if it's not, like, I would irrigate, maybe scrape through a little bit. And if it's persistent, then I might gently open up and irrigate it more and curette some of it out. And what you will see in a low-grade infection is just going to be like a little nest. A high-grade infection, you get an abscess, and that's, then you're probably going to lose your bone graft, the majority of your bone graft, or the whole thing. I mean, the fistula, I think if you manage it well, you should be able to get, and I'm not talking about the periimplants in general. If I have a ridge augmentation, let's say I have a fistula, I get 80% bone if I manage it well. So I think I went through most of the questions, and I think there were some very good questions. I really appreciate that you were spending this evening with us. I think you should think about, always diagnose the classification, like 1-wall, 2-wall, 3-wall, 4-wall, okay? 4-wall, easy. 3-wall, not difficult. 2-wall, very difficult, but do I really need 100%? Do I regenerate? Incomplete regeneration might be able to maintain the implant. Do I combine that after with maybe implantoplasty, or just maintain and keratinize tissue and good hygiene? And maybe that would work out really well. 1-wall and supraprestal defect, obviously, it is very challenging, but it's not impossible. And maybe you will see a case when you need it. And so, yeah, I wish everybody very good luck with this. And patient selection is very important. Case selection is very important. Neighboring implants, neighboring teeth, tissue quality, tissue quantity, fixation, and pre-surgical, instructions to the patient, pre-surgical periimplant mucositis decrease with the patient, maybe some soft tissue techniques with the patient. So, but again, thank you very much, and I wish the best of luck for everyone in this very difficult topic. Goodbye.